Welcome. In this presentation, we'll explore how the management of small renal masses, SRMs, has evolved over the past decade. Drawing on recent evidence and expert consensus, we'll cover changing diagnostic practices, treatment options, and future directions aimed at improving patient outcomes.
Historically, kidney cancer was diagnosed based on symptoms like flank pain, hematuria, and palpable masses. Today, however, the widespread use of abdominal imaging has shifted detection toward incidental findings, over 70% of which are small organ-confined tumors.
Between 20% and 30% of SRMs are benign. The majority are malignant but tend to be indolent with low metastatic potential. Unfortunately, distinguishing between benign, indolent, and aggressive tumors based solely on imaging remains a clinical challenge. Historically, benign tumors were often treated surgically. Today, thanks to improved use of renal mass biopsy, RMB, surgery for benign disease has decreased significantly from nearly 30% to around 11%. RMB is now recognized as safe and accurate with a diagnostic rate close to 90%. The mainstay treatment has moved from radical nephrectomy to nephron-sparing strategies like partial nephrectomy, thermal ablation, and active surveillance. This shift reflects a broader focus on preserving kidney function while maintaining oncologic safety.
Partial nephrectomy overtook radical nephrectomy in 2008 and is now considered the gold standard for operable SRMs. Robotic-assisted techniques are increasingly used, and the emphasis is on minimizing ischemia time to preserve renal function.
Active surveillance has become a viable management strategy, particularly for older or comorbid patients. It involves routine imaging to monitor tumor growth with delayed intervention if necessary. Growth rates are generally slow, averaging 0.3 centimeters per year, and metastatic progression is rare. Thermal ablation, including cryoablation and radiofrequency ablation, is suitable for select patients with tumors, AO3-CM. While slightly higher recurrence rates exist compared to surgery, multiple ablations improve outcomes, and the morbidity profile remains low.
SBRT is emerging as a promising, non-invasive option for localized kidney cancer, offering good local control in SRMs. Research is ongoing to define its long-term outcomes compared to traditional modalities.
Large registries are critical to tracking real-world data on SRM management. These registries offer insights into practice patterns, patient outcomes, and quality improvement opportunities, particularly in reducing unnecessary surgeries. Guidelines from the AUA, EAU, NCCN, and ASCO generally agree on SRM evaluation and management. Initial workup includes labs, contrast-enhanced CT or MRI, and chest imaging. Partial nephrectomy is favored when surgery is needed, with AS and ablation as alternatives based on individual risk. Clinical decision-making often deviates from guidelines due to patient preference, anxiety, or provider experience. Factors like tumor size, location, and the urologist's training heavily influence whether radical or partial nephrectomy is chosen. Multiphasic CT or MRI is preferred for diagnosis. Ultrasound plays a role in AS monitoring. Nephrometry scores like the Renal system help quantify tumor complexity and predict surgical outcomes, aiding in treatment planning.
Patients with hereditary syndromes or pre-existing chronic kidney disease require tailored approaches. For many hereditary RCCs, a 3-cm rule applies, delaying intervention until the tumor exceeds 3 centimeters. For others, earlier surgery may be necessary.
Emerging tools include advanced imaging, molecular biomarkers, and AI algorithms. Techniques like CUS and 99-MC sestamibi spec CT may improve benign versus malignant differentiation. AI promises better pre-treatment stratification and wider use of AS. In summary, the management of SRMs has become more nuanced and patient-centered. With better diagnostics, minimally invasive techniques, and a greater role for surveillance, we're reducing overtreatment and improving long-term outcomes. Continued research will further personalize care for patients with SRMs